well. But even if you're not from Redbridge, this is actually an excellent educational session about the management of hyperlipidemia in primary care, what to do when you get stuck, what to do when patients complain of aches and pains, and if they're intolerant to statins. And it will also give you a very good insight into the pathways that are currently available for optimizing treatment for your patients, and that includes the newer drugs such as bempedoic acid, inclisiran, where they fit into the grand scheme of things. So there is something for everybody today. If you're in Redbridge, obviously it'll be specific bit more because we're doing the pilot. But hopefully, once this pilot is done, this is something we want to do right across, not just BHR, but right across Northeast London. So absolutely essential for everybody. So on that note, I am going to be passing over to Professor Riaz Patel. Dr. Patel is a lipid specialist, and this whole project is really his fantastic effort to get this up and running. As I said, he's a lipid specialist, and he will be over our main clinical oversight on this project. I'll then be passing over to Sadir, who's one of our clinical, consultant pharmacists in hyperlipidemia. And yeah, so if Professor Patel is here, I'd like to hand over so he can give us the introduction to the session, and then we'll hand over to Sadir. Professor Patel, are you here?
Yeah, great. Thanks very much, Imran. So that's a very kind introduction. So just hi to everyone. So I'm a consultant cardiologist. So I know many lipidologists are actually diabetologists and chemical pathologists, but I'm a cardiologist. My focus is CVD prevention, and this is really what this is all about. So it's not just cholesterol. So is someone presenting the slides? Sadir, are you sharing slides, or who's going to be sharing the slides? Lovely, thank you very much.
Yeah, I'm sharing.
Great. Great. So, so what I thought I'd do is I'd just set the scene really about cholesterol management, because I think there's a lot of confusion and misconceptions out in the communities, which I'm sure many of you will probably face. So it's worth spending just a few minutes to get that out of the way before we dive into the nitty-gritty of how to manage cholesterol. So the first thing to say is that LDL cholesterol is absolutely causal for atherosclerosis. Now, I'm sure many of you will remember this sort of diagram from university and school days, but essentially atherosclerosis is driven by cholesterol, LDL cholesterol in particular. Lots of processes like oxidation will take place, which means that not everyone who has high cholesterol will get heart disease, because you need the right milieu inside your body to make it happen. But nonetheless, the fundamental building block is LDL cholesterol. Without it, you cannot form atherosclerosis. And from the 1940s onwards, we've had lots of epidemiological studies. This is Ansel Keys, and one of the famous early population studies. As soon as we could start measuring cholesterol in the blood, we're able to quite quickly do large-scale studies and demonstrate an association between high levels of coronary disease and high levels of cholesterol. So that's one large piece of evidence. The second big piece of evidence about the causality of LDL with atherosclerosis is from genetic data. And we have genetic data in two forms. One is from latest sort of genome-wide association studies and sort of complex approaches that will prove this very linear causal relationship between heart disease, or cardiovascular disease, and cholesterol and LDL cholesterol levels. And then the second, of course, is familial hypercholesterolemia, which I'm sure you may have heard about, but it's a very classical genetic condition where patients will have an abnormality in one of 4 genes that controls LDL cholesterol levels in the blood. And if you're born with 2 mutations, you have this horrible condition called familial homozygous hypercholesterolemia. And that means that people will have heart attacks in their teenage years or early 20s, and many of them will die at that age. If you have heterozygous, you have a milder version where you have cholesterol levels are 7, 8, 9, 10, and you will look normal, but you will be prone to heart disease quite early in life, and maybe in your 30s or 40s. So if you wanted proof that LDL cholesterol is really related to heart disease, that's probably your biggest one. And then the final evidence that we have about the causality of atherosclerosis is in the trial data. So we have lots of trials that have now demonstrated robust relationships between LDL lowering therapeutically and cardiovascular outcomes. And this is from WASCOP's data, which was West of Scotland study in primary prevention, so looking at people without heart disease who were then treated with cholesterol lowering, and it improved outcomes from both mortality and coronary disease. So lots of evidence now promoting the causality of LDL. So when we're managing cholesterol, I think the key take-home message from me, I'd like you all to remember, is really that it's all about CVD risk. Right? Some people get very they tune out when they think it's cholesterol, it's just another biomarker. But actually what you're treating by treating cholesterol is cardiovascular risk. And the reason for this is that we know from all of the studies that we've compiled over time, this is from a meta-analysis from the Lancet in 2005, which is a very famous study. But since then, it's lots more studies have been added to this. But it shows that if you take all of the aggregated cholesterol trial data, if you reduce LDL cholesterol by just 1 millimole per liter, there is a 22% relative risk reduction in cardiovascular events, including major events, as well as coronary heart disease, heart attacks. So that means wherever you start from, if you can bring someone's LDL cholesterol down by 1 millimole, you have given them a fifth of a reduction in their risk. So basically, keep going, bring it down. So wherever you start from, it doesn't matter if you lower it further. And that's really important, because if people have cardiovascular disease already, they may have had a heart attack even with a normal cholesterol, normal LDL cholesterol. So what you need to do then is to bring that LDL cholesterol even lower than where they started from. So we moved away from this concept of thresholds to this concept that you just bring them lower from wherever they start from. Next slide. So that's one thing about reduction. But biologically, as a cardiologist, I'm very interested in this side, and some of you may be as well. So I'm sure people will ask questions around, can you reverse coronary disease? And the answer at the moment is you can't reverse it completely. But we know from incredibly, very careful studies that have been done that show that if you take intravascular ultrasound, you put these tiny ultrasound probes into your coronary arteries, and you treat people with aggressive LDL lowering, what you see is fascinating, is that you start to see plaque stability, and in some cases even plaque regression. So you're starting to shrink plaques. And you can do that if you get the LDL treated LDL cholesterols really, really low. So you can see here there's a nice relationship that you can draw from the studies that have been done that demonstrates that the higher you leave someone's LDL cholesterol, the more likely they are to progress their plaque. So if you take someone who's just had a heart attack and they've had a couple of stents fitted, and now they've come to you, they're not really on optimal treatment, they're not on a statin yet, and their LDL cholesterol is 3, you can see that their plaque volume year on year is going to increase. However, if you've got them on a high dose statin, a 12/80, which is what we commonly use, and their LDL treated cholesterol is now 1.5 or under 2, you can see that they will then hopefully year on year have very minimal progression, and may even be lucky enough to sort of a fractional reduction. It's not big enough to reduce your plaque completely, but it is enough to stabilize it. And you can see that a lot of the guidelines in Europe and others aim for an LDL treated cholesterol in patients of ideally well under 2. So if you're in that sort of 1.4, 1.5 territory of LDL cholesterol, you can see you're in that zone where you're going to hopefully get some plaque stability and plaque regression. So this is why LDL cholesterol is really, really important. Next slide. So the current guidelines, which I'm sure you're all very familiar with, is that patients who have established cardiovascular disease, meaning they've had a heart attack, they've had a stent, they've had bypass, or they've had a stroke or a TIA or peripheral arterial disease, they should be treated with a high intensity statin, which currently the one that uses a 12/80. And the NICE guidelines will say that you should be aiming for a non-HDL reduction of at least 40%. Okay, so it's at least, that's not where you settle at, that's what you're at least aiming for. And there's no targets per se in NICE. So NICE doesn't say get them down to 1.4 or 1.5, but there is a consensus towards a non-HDL of under 2.5 which again is very confusing because some guidelines use non-HDL, some use LDL. But a non-HDL of 2.5 is about an LDL of 1.8, because it's always about 0.7, 0.8 below the HDL value is your LDL cholesterol level. And there's now substantial and growing evidence that the lower is better, right? So get your LDL, crush it right down is where you want to be if you've got cardiovascular disease. Next point. So I said European guidelines, in contrast to NICE, do put a threshold of less than 1.8 for people with stable cardiovascular disease and less than 1.4 if they've got something a bit more worrying, like they've had a heart attack or they've had a recurrent event. So it's quite a low LDL target. And like I said, although we're not pushing towards targets, this gives you an idea of where the world is currently trying to get people with cardiovascular disease. Next slide. So I'm going to finish on how that links to what we're doing here. So in Redbridge, and you can take this probably for the whole of Northeast London, whatever borough you're in, there is a high proportion of cardiovascular disease in Redbridge. You can see the sort of numbers that the BHF have come up with, about 40 deaths a month, 1 in 4 people, which is a cause of about 25% of all the mortality in the region. So in Redbridge, we know from data from KEG and from John Robson's group that around 80% of the 11,000 or so people that we have in Redbridge alone have suboptimal lipid management. And that means that they're not on a high-dose statin, they are not optimally treated with this is not even with LDL levels, this is just they're not on a high-dose statin or they're not on a statin at all. So you can see that if we could just improve this fraction even a little bit, we could make a huge dent into premature and preventable causes of cardiovascular disease just by extrapolating, like I said, that 1 millimole reduction and 22% relative risk reduction. You can see an enormous difference that could be made. So hopefully I'm going to hand over now to Sudhir to tell you about the project that we've initiated in Redbridge. But this is not unique to Redbridge, and the plan is to pilot it out, get it working in Redbridge, and then to roll it out across the region. But I hope that by taking away the lessons from today and the sort of the tips and the advice that we can give you, you can actually start implementing in your clinical practice in whatever region you're in. You don't have to wait for this project to roll out. The guidelines are all published and they're all pretty standard. But I hope I've convinced you why cholesterol management is important and why it's not just about numbers, but it is really about risk reduction. Well, I'll stop there and I'll hand over to Sudhir.
Thanks, Riaz. Can everyone hear me okay? Perfect. Many thanks for that and for setting the scene. My name is Sudhir. I'm lead cardiac pharmacist at Barts Hospital. I also work very closely with Professor Patel in the PCSK9 clinic, managing patients with very complex CVD and statin intolerances. So the next couple of slides, what I'm going to do is discuss the lipid management guidance that's available and hopefully dissect it down for you to see how it works in practice. Now, Riaz has already very nicely explained the relationship between LDL and CV events. And we know that high cholesterol is one of the most significant risk factors for CVD, and effectively the lower the better, as just described. Now, what you can see on the screen is a number of studies that look at statins in both primary and secondary prevention. So up here we have the 4S study, which is really when we first started using statins for secondary prevention of cardiovascular disease. And what you can see is that for patients on placebo, they had an event rate in which they had one or more coronary event of about 28% versus 19% for those on simvastatin, just 20 milligrams, which was up titrated to about 40 milligrams. So this is when we really started using statins post events and really when we started transforming CV prevention. The Prove It study is when we really then started to look at high intensity statins. And what that did was it compared pravastatin 40 milligrams, so a low intensity statin, I'll come on to what that means in a couple of slides, which achieved an LDL of about 2.5. And it compared that to patients with atorvastatin 80 milligrams to get their LDL down to about 1.6. And what that did was it reduced the primary endpoint, which would have been a major coronary event, things like angina, heart attack, stroke, etc., down from 26% to about 22%. So an additional 16 relative risk reduction. So this then became the era of giving high-intensity statins, and this is where a lot of the guidance came from. And you can see that even in primary prevention studies, this theory still holds, although the event rate is much lower, noting this cohort of lower risk patients. And similar to what Riaz just said, so if you bring down the LDL by 1 millimole per litre, regardless of intervention, and again, there's an annual risk reduction of a fifth to a quarter. So the lower, the better. So the Accelerated Access Collaborative have developed this guidance to summarize the NICE guidance for both primary and secondary prevention. And it was recently updated in August 2021, although I believe it's currently being updated again, considering there's newer options available. And it talks about initial considerations to rule out secondary causes of hyperlipidemia, and also provides guidance in how to risk stratify patients as to who should be on atorvastatin 20 milligrams for primary prevention. It then provides guidance for secondary prevention and effectively giving people atorvastatin 80 as per the evidence, and how to escalate or intensify therapy, and also provides some information on familial hypercholesteremia and how to recognize and identify that. And it's a 2-page guidance. It's very comprehensive. It's also got some very useful information about statin intensity, how to monitor people on statins, thresholds, etc. So what does the guidance say? So this is a schematic trying to explain the guidance in a bit more digestible format. And I'm focusing here on secondary prevention because a lot of the work that we'll be doing is on secondary prevention. So if during your consultations you come across a patient who has a diagnosis of angina, previous myocardial infarction, revas, so they've potentially had a stent or a bypass, stroke or TIA, then effectively they should all be on atorvastatin 80 milligrams daily. So question 1 is, are they on a high intensity statin? And if not, the question should be, why not? And that should sort of stimulate the conversation. At the same time, you should be looking at all the identify all the modifiable risk factors and managing comorbidities such as blood pressure, diabetes, smoking cessation, alcohol moderation, diet and exercise, etc. But essentially, all patients should be on atorvastatin 80 milligrams. You may wish to consider a lower dose if patients are on interacting medications. Amiodarone is a good example. Or if you are concerned about patients having a high risk of experiencing adverse drug reactions. So the frail, the elderly, so patients over the age of 75, female gender, hepatic impairment, any personal or family history of muscle pains, you may wish to go for a lower dose, say atorvastatin 40, or 20 in patients with CKD, EGFR less than 60. Once the statin has been started and have had their baseline tests, if the patient can tolerate it, then you should repeat their blood test 3 months later. And at that point, you want to repeat their full lipid panel, and you also want to check their LFTs. The aim, as Riaz had stated, as per NICE, is to aim for at least a 40% reduction in non-HDL cholesterol if you have a baseline. And if you don't have a baseline, then again, you're aiming for an LDL of less than 1.8, not that we have targets, the lower the better, but that's your rough target, or a non-HDL of less than 2.5. So hopefully you can achieve that. But what we know is that about 80% of patients on lipid-lowering therapy do not achieve this target. And if they don't, what you would want to do is talk to them about adherence, the timing of the dose. Perhaps they need to move it earlier in the day because it's quite long-acting, diet and lifestyle measures, etc. Now, if they don't tolerate the statin, they would follow the AAC statin intolerant pathway, which I'll come on to in the next couple of slides. At that point, they'll either be on a ezetimibe, or you'll get them back onto a dose of a statin. However, you want to make sure that you repeat it at 3 months. When you're looking at liver function tests, you may see a transaminitis where some of the liver function tests elevate. That's not too uncommon with statins. If it elevates to more than 3 times the upper limit, you would stop the statin, repeat the LFTs a month later, and if it resolves, reinitiate at a lower dose. However, if it remains elevated, then you would refer the patients for assessment to hepatology. Now, at this point, if targets aren't achieved, and I use the term targets loosely, but if we don't achieve these targets, then you would either look to intensify therapy. So if they were on a TORVA 40, you may wish to go up to a TORVA 80, or add in ezetimibe at this point. And you can see that the intensity of a statin denotes how much reduction in LDL it will bring someone's cholesterol down by. So a high intensity statin will bring your LDL down by at least 40%. So that includes a TORVA 20 up, Rasuva 10 up, and moderate, medium intensity statins bring it down between 31 to 40%, and low intensity statins bring it down to between 20 to 30%. Apologies, one moment. So you would look to intensify the therapy or add in additional treatment. And at that point, again, you would repeat lipid profile 3 months later. Now, at that point, if you achieve an LDL of less than 1.8, then again, technically you could say your target is met, unless you are very concerned and you may wish to drive it down even more, but that's what we are aiming for. Now, if the LDL is greater than 3.5, then they may meet criteria for some of these advanced therapies like PCSK9 inhibitors, and they can be referred into our lipid clinic at Barts or our PCSK9 service, where we can assess patients and initiate them on some of these therapies. And they're very effective at bringing cholesterol down, and I've attached the criteria, which really is dependent on LDL levels, which is why we like looking at LDL over non-HDL, because NICE criteria is based on LDL, and their risk either being high or very high, depending on whether they have had recurrent events, for example, and if they have FH. I've added bempedoic acid in here. Again, if patients meet criteria for PCSK9, this would be preferred over bempedoic acid, which is reserved for patients who are statin intolerant, who don't achieve targets with ezetimibe, and this can either be on its own, if ezetimibe isn't tolerated, or in combination with as Nustendi, if targets aren't met, but PCSK9 criteria is also not met. The reason why PCSK9 is preferred is because there's good cardiovascular data for them, which is lacking at present for bempedoic acid, and also the reductions of PCSK9 is at least 60%. It's very, very effective at bringing cholesterol down. I'm sure you're all aware that inclisiran has just been approved, and again, there'll be lots of discussions as to where inclisiran fits into practice, but we know that patients who have cardiovascular disease with an LDL of at least 2.6 can be offered inclisiran. So there'll be a cohort of patients in which case inclisiran will be appropriate for. If targets are met, then at 12 months, you would repeat their LFTs, and then you wouldn't do it again unless clinically indicated. And at that point, you should also consider doing an annual non-fasting full lipid panel to assess treatment adherence. And it'll be always worth doing it on a yearly basis, just to stimulate those discussions. We know adherence rates for cardiovascular medications aren't very good. And so annual reviews and assessing for lipid panels is a good way to make sure they're still taking their medication. So the AAC have also developed this statin intolerance pathway. The reason is because stopping statins is associated with an increased risk of major CV events. And there is this growing concern that clinicians are labeling patients as statin intolerant too quickly. And there's certain terminology like the nocebo effect and statin reluctance. There was a study that was recently published about a year ago in which 60 patients either took nothing for 4 months, either took atorvastatin 20 milligrams for 4 months, or they took a placebo medication for 4 months. And they took these at random. They didn't know whether they were having atorvastatin or placebo. And they were asked to grade their pain between 0 to 100. So 0 being no pain and 100 being the worst pain imaginable. And what they found was that 90% of the patients that had side effects on statins also had side effects when they were taking the placebo. And so this is what we term this nocebo effect. So just taking a tablet, regardless of whether it has the active ingredient or not, seems to cause patients side effects in the anticipation of getting these side effects. Statin reluctance is patients who are reluctant to take statins, not based on any personal experience, but perhaps friends and families. So this guidance is really trying to help mitigate some of these nocebo effects to truly denote someone as statin intolerant. And again, it's a 2-page document, and it gives some very comprehensive guidance as to how to manage muscle pain. So again, what does the guidance say? So if there's new onset or worsening of typical muscle symptoms since starting statin, so the timing of symptoms is very important to generate a causal effect. If the pain was there prior to initiating the statin, again, it may not be due to the statin, but if it's new onset or it's worsened since starting the statin, and by typical symptoms, I mean symmetrical pain, weakness in large proximal muscle groups, and it worsens on exercise, then it could be statin related. If it's atypical in nature, what you want to do is try and reassure the patient that it's probably not statin induced and look for secondary causes of pain. So you'd want to check vitamin D levels to rule out vitamin D deficiency, thyroid hypothyroidism, bone profiles, etc. Rule out polymyalgia rheumatica. So there's various other causes of muscle pain. However, let's say it's typical. What you would want to do is measure the CK, and the range is between 22 to 198, and depending on how much elevated it is above the upper limit of normal will classify its the statin-related muscle toxicity into varying grades. And these lower classifications are quite common. These are much rarer. So if there's no elevation in CK, and it's tolerable, then that's classified as SRM1, myalgia tolerable. And you would just continue if the patient is happy to do so on the statin that they're on and the dose. If it's intolerable and the CK elevates to less than 4 times the upper limit of normal, then that's myalgia intolerable. If the CK elevates to between 4 to 10 times the upper limit of normal, that would be SRM3 or a myopathy. If it's between 10 to 50 times the upper limit of normal, that's graded as severe myopathy. If it's above 50 times the upper limit of normal, or if it's greater than 10 times the upper limit of normal, but there's evidence of renal impairment, that's quite rare, but that you should suspect rhabdomyolysis, and that those patients need urgent inpatient assessment for fluids, stopping the statin, etc., and assessment. And if symptoms don't resolve, then that's classed as statin-induced necrotizing autoimmune myopathy. And again, those patients will need referral, and they will need muscle biopsies to detect the presence of HMG-CR antibodies. If the patients get these symptoms, then what you want to do is stop the statins for about 4 to 6 weeks. And what you do is you enter what we call this de-challenge, re-challenge cycle. And after 4 to 6 weeks, you want to repeat the blood test to see whether the CK has normalized and the symptoms have resolved. If the CK normalizes but the symptoms don't resolve, again, it's very unlikely that it was statin-induced. So again, you should re-explore other causes for muscle pain. If the CK doesn't normalize and the symptoms don't resolve, again, you might want to refer these patients for inpatient assessment, as they may have this statin-induced necrotizing autoimmune myopathy. So again, you would refer for consideration of that. However, if the patient has the symptoms have resolved and the CK has normalized, you would restart at a lower dose or a lower intensity statin, or trial an alternate statin, provided the patient has been symptom-free for at least 2 weeks. If they haven't been symptom-free for at least 2 weeks, then just wait for that period of time before you reintroduce the statin. And in practice, generally speaking, if they're on a 12/80, we tend to go down to 40 or 20. If they can't tolerate a 12/20, then rosuvastatin 10 milligrams would be sort of the option. And if they can't tolerate that, then 5 milligrams. And atorvastatin and rosuvastatin are long-acting statins, so there's even data to suggest that rosuvastatin on alternate days or once or twice a week is still beneficial, and there's good evidence for that in cardiovascular prevention and risk reduction. Also, some strategies, as you can see, that if you add in ezetimibe, you get greater reductions than you would in just doubling a dose of a statin. Now, if they can't tolerate atorvastatin and rosuvastatin, you should really trial 3 different statins before you label someone as statin intolerant. And in practice, the most logical option would be to move on to pravastatin. And the reason is because, as you can see, all doses are low intensity, and it's more hydrophilic than some of the other statins. So the theory is that it's less likely, or one of the lower statins that's likely to cause muscle symptoms. There's also some guidance on these consultations and how you would reinforce targets, explain the benefits of statins, as it can be quite challenging to get them to trial a 3rd statin at that point. However, if they're unwilling to do so, and you've been through the motions of rosuvastatin even weekly or pravastatin, at that point you would confirm them as statin intolerance, and they should be coded as such, so that we don't retrial to re-challenge them again. Also, if they're on rhabdomyolysis, it's not good practice to restart them. And at that point, ezetimibe with or without bempedoic acid would be an option, or specialist referral again for PCSK9 or inclisiran, depending on where it sits in practice. So this is sort of summarizing, again, both guidelines, not only for the lipid management pathway, but in practice, how you would manage someone with muscle pain. Now, I'm going to carry on with the session. Satiris, who's a consultant pharmacist here, unfortunately couldn't do the next couple of slides, but it was just to sort of talk through a bit of the lipid management pilot program that we are planning on doing in Redbridge, with a view that this gets rolled out across BHR. So Public Health England have produced various documents and guidance on what healthcare professionals can do to improve cardiovascular disease. It's big on the NHS agenda. It's big on the 10-year forward or the NHS 10-year plan, looking at cardiovascular disease. And there's a big drive and focus. And what can we do is, well, we can find the patients, we should treat them in line with NICE guidance, and we can optimize their therapy. And this pilot program, we are effectively doing that. There's lots of different ways you can do that. Now, UCL Partners have produced this proactive care framework back in February 2021, again, to support clinicians in managing these patients and risk stratifying them and targeting easy wins. So what can be done? Well, healthcare assistants, trained professionals can gather data. There's lots of ways to do that. KEGG tools, make sure that bloods are up to date. So we talk a lot about LDLs, but have they even had a blood test done within the last year? Do we have cholesterol readings? Do we know what their blood pressure is, weight? So get the information, support patients with education, how to monitor blood pressure, to take control of their own lifestyle, and then supporting behavioral change. So again, other big interventions are smoking cessation and supporting their other risk factors. Then you would stratify the patients. So the biggest priority are those with established cardiovascular disease, not on a statin. So those would be the patients to target first, want on a statin, and try and optimize and get them on a statin. Then you have priority 2, which comes in 2 parts. So on a suboptimal intensity statin, so for example, simvastatin 40 milligrams, a medium intensity statin instead of a high intensity statin, or a suboptimal dose. So they may be on a 12/40, and they could be on a 12/80. And in priority 3, so the least of the priority, have suboptimal levels despite maximal therapy. And that's really looking at some of these more advanced therapies to see whether they should be referred in for PCSK9, should we add in ezetimibe, etc. And then the prescribing clinicians, what they should be doing to optimize these patients. So if we look at Redbridge, there's 42 practices across 6 primary care networks. We've pulled this from KEGG data, and there's approximately 11,000 patients who've been coded with ischemic heart disease, peripheral arterial disease, or a stroke or a TIA, aged 18 plus. If we break these down into the priorities, about 20% of these patients are not on a statin. So there are a huge number of patients in the community who have established cardiovascular disease. We've just gone through all the rationale as to why they should be, and for some reason they're not. It may be appropriate, it may not, but again, we need to see whether these patients have either gone down a statin intolerance pathway or whether it was oversight or why they're not on a statin. There are approximately 40% of the patient on suboptimal intensity statin, and again, about 20-ish% on a suboptimal statin dose, and about 10% of patients still not achieving target despite maximal use. So like Riaz had said, about 80% of patients in Redbridge have suboptimal treatment, and we need to do something about them and to help manage them. And this pilot program, what we will hopefully achieve is really improving cardiovascular management in this cohort of patients. So we are piloting, and we're still working out the logistics of how it will work, and we'll be piloting in a few practices first. But the idea is that we will use tools like KEGG to pull data and to identify these patients. And we will stratify them into those, not in the various groups. And there'll be a lot of collaboration between specialist hospital-based cardiac pharmacists and PCN pharmacists to do joint desktop reviews to try and optimize these patients. And there'll be obvious ones which can just be managed in community. There'll be borderline complex patients that need discussion. They may have comorbidities that make things a little bit more complicated. So there'll be lots of MDT working and supporting of education and upskilling. And then there'll be clear referrals in and pathways into our lipid clinics to initiate patients on PCSK9s. With inclisiran coming out, we'll be able to pilot some of these newer therapies as well. So, and at the same time, there'll be some background work trying to support identification of possible FH patients. And again, there'll be lots of education that comes with this. So this sort of is what we envisage for this pilot. We're still working out the exact specifics of it. There's some additional resources on the UCLP website, so do have a look at it. It sort of gives guidance on secondary prevention, primary prevention. We've also been through the AAC pathway, so do have a look at those. FH, it goes through what to do with abnormal liver function tests, etc. So there's lots of materials out there, and again, there's lots of things you can direct patients to through BHF for them to start taking an interest in their own disease. That is it from me. I'll just hand you over to Imran to sort of give the final updates on what sort of teaching is out there, and then to close. Thanks.
Thank you. Well, first of all, can I just say a big, massive thank you to you and to Riaz. That was eye-opening, that was informative, that was absolutely fantastic. So I've certainly learned quite a few things. So big thanks to the both of you. Following on from this, we will be arranging some more sessions, especially around case studies. We'll be looking for you to bring your own case studies as we get on with this program. Maybe some patients where something unusual or very intolerant to statins or whatever it may be, or potential familial hypercholesterolemia. And we will hopefully engage in some joint sessions so that we'll get some learning out of it. We'll also be looking at familial hypercholesterolemia, how to recognize it, and then obviously get those patients referred into our specialists. And that's all to come. We'll get back to you with the exact dates as we try and organize it. The only other thing I would say to you is get this as part of your normal routine of work. So if you're doing a diabetes review, and maybe it's a diabetic who's already had a history of MI, just have a look at their cholesterol, see if they're on the right statin. If they're hypertensive, I've had a stroke or a TIA in the past, I've got peripheral artery disease. Again, while you're doing the hypertensive review, have a quick look at the cholesterol. When you're doing your SMRs, you may be able to look at these patients. So build it into your everyday practice. Don't make it something special. This should be done as normal. And we should be looking at these patients and optimizing their treatment as appropriate. Is there any questions? If that's okay, Sadir, Riaz, from anybody? Yeah.
Yeah, very happy to take some questions if there are any. Or people can put them in the chat if you want.
If you're shy.
Hi, can I ask a question, please?
Yep.
Hi, it's Manfred. I'm one of the practice pharmacists in Ilford and Chigwell. Just a question I wanted to ask was just with regards to patients who, when about fibrates, because I didn't really see fibrates mentioned so much in the presentation, and if that's something that could be started in primary care, and if so, I mean, when would we start things like fibrates?
Shall I take that one? So fibrates are not used to reduce cardiovascular disease risk. So if you look at the NICE guidelines, it says, there's a big sort of no to using fibrates or plant sterols, stanols, the sort of other stuff that are available to us. And that's because there's no data to suggest that fibrates reduces cardiovascular disease risk at the moment, right? So we don't have any data. So it's not in the main guidance and we don't recommend using it. However, obviously in a specialist setting, there might be some people that you need to use it in. But that would be sort of maybe one of these that we would have the MDT discussion about, or we'd have an advice and guidance for, and so on. But for cardiovascular risk reduction, we only use the ones that have got outcome benefits, which are the ones that we've listed there. While we're on that point, I think the triglycerides is a really important factor to remember. We are talking here about LDL cholesterol and non-HDL cholesterol. Triglycerides are not proven to be causal for heart disease at the moment. However, they are a risk factor for pancreatitis. So sometimes if someone has very high triglycerides, we might need to start them on a fibrate to reduce the triglycerides, but for the purposes of pancreatitis risk, not cardiovascular risk. Okay, but so basically, if you're ever wondering that someone might need a fibrate, ask some or get in touch with us or however you want, but you shouldn't be really using it for cardiovascular risk reduction.
There was a question around searches, so I'll take that one. Yes, one of our colleagues from secondary care, Nadia, will be helping you within your practices to run the searches, identify the patient. So one of the things you could do is, if you've got your search done and you look for their comorbidities and when you're doing your QOF reviews and your diabetes reviews and your SMRs, and specifically look out for those patients. So yes, there is a search. We're just in the processes of tweaking that search. We have got a search, we just need a little bit of fine tuning. And then Nadia, who will be working with Riaz and Sadir, will be coming out to you and going over the searches. So yeah. Start statins upon diagnosis of diabetes. It depends on the cure risk. If they're a type 1 and they've had diabetes for more than 10 years, then we automatically classify those as a high risk patient. But if they're a type 2, not necessarily do a Q risk. If the Q risk is more than 10%, you would be starting a statin. Is that okay, Riaz? Would you agree with that? Hope I haven't messed up there. Sadir's nodding his head, so I've learned something.
Yeah, I think that's generally correct. I mean, end organ damage. If someone has end organ damage with diabetes, it's another reason to think about statins. So if they've got stages of nephropathy, neuropathy, retinopathy, you'd certainly want to think about in those people too.
Sorry, but doesn't QOF usually dictate that? I've used the word dictate, but doesn't that usually say that, you know, anybody who's diabetic should be considered for the statin? Like
No.
For 20
No, if you look at the NICE guidance, QOF doesn't say that. What QOF says, if they are on a statin, from memory, if they're on a statin, I think it's I can't even remember if the targets are still in there. Even they may have gone.
Sorry,
but I think it's still 4 and 2, isn't it? I think for QOF, off the top of my head, total cholesterol 4 and LDL less than 2. At least it used to be.
No, sorry, I shouldn't have actually said QOF. What I meant to say was NICE.
Yeah, so NICE doesn't set target. NICE is looking for a 40% reduction in their LDL. And that's what we should be looking at. Because remember, we've moved away from target setting. What we're looking for is that 40% reduction in their LDL is the way we kind of assess plaque stabilization. It's the way we can assess whether the statin is actually working or not in that patient. Because if you get that 40% reduction, I think it was Dr. Patel who, didn't you show in one of the first slides that if you get that 40% reduction, you actually stabilize that plaque, you prevent it from getting worse. And I think there was a rosuvastatin high dose study that even showed some regression. I think it was 20 plus milligrams of rosuvastatin, but I'm getting old, I can't remember exactly. But I think there was one of those studies. That's why you're looking for that 40, but the key thing here is, have they had at least a 40% reduction in their cholesterol? If you can't work out whether they've had a 40% reduction or not, then at the minimum, aim for less than 1.8.
I mean, just that point about diabetes is important because generally speaking, if someone has type 2 diabetes, it's more than likely that their 10-year risk is going to be approaching 10% or above 10%. So what you'll find in practice is that most people who have type 2 diabetes should be on a 12 or 20 milligrams, right? So that's type 2 diabetes. But the NICE guidelines does suggest that you should, because what they're saying is that if someone's very young, say they're 38 or something, and they've got type 2 diabetes and nothing else, their 10-year risk might be low, so you might defer their statin for a few years. Now, whether that's right or wrong is another discussion, but that's what NICE is saying. But for type 1 diabetes, like Imran says, if they've got type 1, they're kind of considered pretty much high risk. And if they're older than 40, if they've had type 1 diabetes for more than a decade, I think they've got end organ damage and something else, they are eligible. So most type 1s, again, because by the age of 40, they will almost certainly have coronary disease. And then they fall almost into this bracket of people with cardiovascular disease. So treat them as very high risk, once they get to that stage.
Can I ask? Sorry, I have a patient today, and he was on atorvastatin 40. Sorry, and the doctor's given her naproxen because she's getting muscle pain aches. She's obviously been through the 10, 20, and 40. I don't think that's right, but I mean, do you know anything I don't?
I'll let Sudhir take that one if you want, maybe.
Yeah, no, I personally wouldn't give an NSAID to deal with statin associated muscle pain if they've put it down to the statin dose. And again, if you follow I don't know whether the patient had a CK done to see whether it was due to statin. Perhaps they did, and it wasn't elevated, and they felt that maybe it was more musculoskeletal or inflammatory type pain, in which case naproxen could be given, but not for statin-induced muscle pains.
Okay, so would you say do CK and then see what comes out of that for continuing NSAID? Fine. Thanks for that.
Yes, not only for continuing NSAID, but also for considering a lower dose or a different intensity. Yeah. It would be worth seeing what their full lipid panel is, and also looking to see what their CK is as well.
Thanks for that.
So so from a primary care perspective, one of the things that I find that happens in practices is patient has a statin, they come back, they go, you know what, since I've been on this, I've been getting muscle ache. And then whoever the HCP is says, oh, well, it's probably the statin, we'll stop it. Or we'll go straight to pravastatin, or you know, something like that. We haven't done the CK levels. How do you know it's the statin? So if you come across this and you go and speak to your GP leads and say, look, started this statin, you know, 6 weeks ago, they've stopped taking it, they've got muscle ache, then if the GP doesn't suggest it, there's no harm in you suggesting it. Just say to the GP, is it okay if I do a CK level just to see where we are with this patient? So yeah, don't be shy. Sometimes GPs, you know, they're human as well, they can forget.
Just to say that the education program we're working on is for primary care GPs as well. So there's a lot of education to this. I mean, there's some subtleties, but there's hopefully with this program we'll just train everyone to really sort of understand contemporary management of these issues.
Also, I think, you know what, we with the backing of people like Riaz and Sadir, I mean, sometimes we have a fear ourselves of, okay, this patient's got peripheral artery disease, but their cholesterol's, you know, 4.7, their LDL's 2.1, you know, do I really want to give them atorvastatin 80 milligram? You know, are they going to get that muscle problem, and then their ALTs are going to shoot through the roof, you know, and I'm the prescriber here, you know, oh God, you know, am I going to take that clinical responsibility for all of this? Let's just give them 20. So that does happen. So I think sometimes, you know, when it's natural to err on caution, but I think through this project we'll become braver. Let's put it that way. And you know, sometimes yes, the 80 is not tolerated, but at least give the 40 or even the 60, a 20 and a 40. So hopefully it will build our confidence as we go through this.
Yeah, and I'll just echo exactly what Imran has said, is that this is all about building confidence in you guys to feel enabled that you can, you know, easily treat all of this. It is, you know, our experience is that everyone who comes through the Bart's Heart Center who has a heart attack is put on Atorva 80. You know, it's a standard practice. We don't think twice about it. Yes, there's some people who might not be able to take it, but, you know, we need to give everyone a chance. Let's give everyone a chance. Let's go hard on people's LDL cholesterol, and let's try and reduce the CVD risk that's associated with it. There really is, you know, there's very few drugs out there that can protect people from subsequent cardiovascular disease once they've had an event, you know, and statins are absolutely proven, as is, well, actually LDL lowering is absolutely proven strategy. Whether you do that with a statin and then later on with ezetimibe, inclisiran, PCSK9, is completely doable. I know someone's mentioned a comment in there that inclisiran's not yet been agreed for primary care initiation. We're fully aware of that, and I think that's a whole discussion in itself. But there will be ongoing discussions about how we build inclisiran in, you know, whether it's primary care initiated, secondary care initiated. Obviously, nice once it's done in primary care, but yeah, we're aware of that, and you know, we will feed you guys with all the information as soon as it's kind of a bit more clarity around the topic.
Riaz, one of the pharmacists are asking, the difference in percentage reduction between Atorva 40 and 80 is about 5%. Is there not a case for trying 40 milligram in those with multimorbidities? Is there not more evidence for Atorva 40 versus 80? Any thoughts on that?
I'm happy to take this one. Sorry, Riaz.
I was going to give it to you anyway, don't worry.
Well, 2 points. Firstly, coming to this question. So yes, agree. So atorvastatin 40 milligrams, you get a 49% reduction versus Atorva 80, which is 55%. And if you look at the statin intensity table, you can see that adding in ezetimibe gives you a greater reduction than just doubling a statin does. So if you are concerned about side effects, then ezetimibe with a slightly lower dose of statin might get you even better reductions in LDL than you would just by simply doubling, where you have a greater risk of getting adverse effects. So that is a good strategy in trying to mitigate some of these symptoms.
Okay,
In terms
brilliant.
of evidence for it, well, the evidence that we have is for a 12/80, which is why everyone goes on a 12/80. The evidence that we have for ezetimibe is with simvastatin. That was the Improve It study, and they had to recruit loads of patients, and you get a benefit over 7 years for treating these patients. So there's no evidence for say 40 and ezetimibe 10 in that specific combination in a clinical trial, but there's enough evidence to suggest that just drive the LDL down with CVD preventative medication that have been proven to lower LDL is the way to go. So yes, I completely agree with that point. The only other point I wanted to mention, just off the back of what Riaz had said previously, is that Samson study that I discussed, where patients didn't know whether they were taking placebo or whether they were taking the statin. They actually managed to re-establish half of the patients on statins. And Imran had said, well, people are very quick to just say, well, this guy had muscle pains and they're off statins. So if you do follow the pathways, it has been shown to get people back onto statins. And that's why we really wanted to go through the pathway in significant detail. Is there concerns going too low for cholesterol? Riaz, I'll let you deal with that. I think the answer is no, but.
Correct. So the latest data suggests that there's no real lower threshold. And the reason we know this is because there are people with genetic mutations who have LDL cholesterols of around 0.3, which is around a total cholesterol probably of around 1.5 or 1.8 or something like that. And these people are completely fine. They're fertile, they're normal cognitive function, absolutely normal. So generally speaking, we don't think that there is a lower level of safe cholesterol, because your body can make all of the cholesterol it needs, and it will do in different processes. So you don't worry about that. In our practice, we have patients on PCSK9 who will routinely have LDL cholesterols of under 1. So they'll be 0.7, 0.8, which is around a total cholesterol of about 2 or thereabouts. So it's perfectly safe. And if anything, the data suggests the lower the better. So the analogy I give to people is that if you imagine cholesterol, LDL cholesterol is the building bricks, and you're trying to make a wall, right? You can't make that wall without the bricks. You might need the cement, so the smoking and all the oxidative stress and everything else, but without the bricks, you just can't make the wall. And so if you take away all those bricks, down to the minimum, you're not going to be able to make that wall. So that's the way to think about it. It's the substrate for atherosclerosis and CVD risk. Good. Any other questions? Imran, anything else we need to cover?
I think that's if nobody else has got anything else. Yeah, that's brilliant. Once again, I really want to thank the both of you, because that really was fantastic. And it was some great learning there, and I certainly appreciated it and learned quite a bit today. So we'll follow this up in terms of the next steps. Will be we'll do another session. We'll arrange that, and what we'll be looking at maybe is getting some case studies in there, some tips and guidance on how to actually do reviews, some of the challenges that you might be facing. So more of the nitty-gritty stuff, if you like, of the day-to-day management of these patients. But I think certainly we've had a fantastic intro and some great learning. Thank you very much. Really appreciate it.
Great. Thanks, everyone.
Thank you.
Cheers.
Thank you. Okay, bye-bye, everybody, and good luck.